Good afternoon. Welcome everyone to the 2024 PI Conference and our 1:30 session, Demystifying Lab Results. My name is Julie Magnuson, Research Project Manager for the Immune Deficiency Foundation, and I will be your moderator for today's presentation. This session is 45 minutes in length, and we will be sticking to that time frame. If time permits, we will be happy to take a handful of questions after the presentation. I'd also like to take a moment to share that this session is sponsored by Pfizer, and we'd like to thank our generous sponsors for their support of our educational programming and community services. Please also note that the information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. And here at IDF, we offer a wide array of educational presentations, including presentations developed by healthcare and life management professionals invited to serve as presenters. The views and opinions expressed by guest speakers do not necessarily reflect the views and opinions of IDF. But without further ado, I'm proud to introduce our presenter, Dr. Mark Riedel. Dr. Riedel is Professor of Medicine and Clinical Director of the USHAEA Angioedema Center at the University of California, San Diego, where he also serves as Clinical Service Chief for Allergy Immunology. He is a member of IDF's Medical Advisory Committee, and he directs an active clinical research program at UCSD focused on angioedema and immunodeficiency conditions. And for full bios on our presenters, you can see that in the conference app. Thank you, Dr. Riedel. The floor is all yours.
All right, well, thank you very much. Thanks for the invitation to be part of the meeting and for attending. The good news for being after lunch is you're full, you had a nice break. The bad news is there's a tendency to get drowsy, right? So I'm going to do my best to keep you engaged, keep you involved, and we're going to talk a little bit about laboratory tests, demystifying laboratory tests. I hope you're enjoying Chicago. Everybody been to Chicago before? Is any first-timers? Yeah, okay. I went to school here many moons ago, more than I'd like to say, and I always enjoy coming back. So I hope you get a chance to get out and see a little bit of the city. It's a beautiful city. These are my disclosures. I do work with a lot of companies in developing, mostly research to develop new treatments. I'm really not going to talk about treatment today, so I don't think this is going to have any influence on what I tell you. And so what we'll talk about is immunological testing. Now, I'm going to spend the first few minutes just talking about some background because I think it's important to understand a little bit how we think about these tests when we order them. But then I'll jump in and talk about a few specific tests, run through a list of things that you or your family members may have seen and discussed with your physicians and sort of how to view those, how they're done, and what they might mean. So, talking about immunodeficiency, of course, and this is the clinical setting that I work in. Doc, I need you to check my immune system, or check my son's immune system, or my husband's immune system. Something isn't right. And I put this up here because this is, in fact, the most important diagnostic test that we do as medical professionals, is to hear your story, to talk to you, to listen to what's been happening in your life with your health. And I just listed some things that are important that you communicate, that we hear carefully. The frequency of infections that don't get better when we expect they should, opportunistic or unusual infections. Family history is very important, as we all know. We'll talk a little bit about genetics in a moment, but we should be asking about your family, your parents, your siblings, any history that might be relevant to what you're going through. And then, increasingly, as you're aware, we know that immunodeficiency conditions, or inborn errors of immunity, are more than just infection. They involve other inflammatory conditions in many cases, and so here you see autoimmunity, GI problems, pulmonary issues, sometimes malignancies. So this is very important because, number one, it tells us where we need to be looking, and that's important. And it's also very important when we get the results back. These labs are unimportant in a vacuum, just numbers on a page. The only thing they're relevant for is you and how you're doing with your health. And I often tell our residents and fellows that come through, we as physicians, we don't treat lab numbers, we treat people. And so you can, yes, we need to check the labs, we need to interpret the labs, but the only reason they matter is because there's the person on the other end that's having a problem, having symptoms, having health issues. So this is very important. Don't forget, as we talk about this, critically important that you interpret anything that you get back from the lab relevant to how you or your family member are doing. All right, so I put this up. This is a little tongue-in-cheek, right? This is complicated on purpose. But it's just to show you, this is the amazing, astonishing, complicated system that we have to try to sort out, that we have to try to sift through when we do laboratory testing. And I realize if you have an immunodeficiency, it doesn't seem so amazing or astonishing because it's not working correctly. But it is pretty remarkable. This is a simplified version of the complexity that our immune system, our body works with to keep us upright, functioning, and not dropping dead as soon as we walk out and get exposed to a bacteria, a fungus, or whatever might be trying to invade our body. And so it's complicated. I'm going to try to break this down for you a little bit, but understand that we're still learning, right? We don't have all the answers most of the time. Here's some of the immune cells. One of my favorite immune cells in the middle there is the dendritic cell. I think there was a talk earlier today about the immune system. Has all these tentacles. It's always sampling the environment and showing the immune system what's going on. And even the dendritic cell, who's got his hands in everything, is telling us, good luck, all right? Good luck figuring out this mess sometimes. Now, the other complexity, which you know very well, is that there are hundreds and hundreds of immunodeficiencies or inborn errors of immunity. And so this is a committee that others may have shown, but every year or two, a committee gets together and lists all the new discoveries in immune deficiency. And this is how many there have been discovered in the last couple of decades. I won't tell you exactly when I did my immunology training, but I can tell you it was towards the top of this graph. And the number of immunodeficiencies has quadrupled since I did my immunology training. So keeping up is a challenge. But we do our best, and we recognize we have more and more refined ways to look for these types of problems. And these problems come in a variety of categories: antibody deficiencies, syndromes, combined immunodeficiencies, complement, and so forth. So we'll talk a little bit about each of these. And really, this is where the history becomes so important. We need to know where to look. We need to know which system to look in based on what you're going through and the problems you've had. So let's break this down a little bit. I mean, we like to think we're pretty smart as humans, and we are, but we need to sort of simplify things in order to do the assessment. So I told you that the history is very important, and I've listed here some of the clues that we need as physicians, as healthcare professionals, to figure out where should we spend our time looking. So you can see people that have a lot of fungal or viral infections, that could be a T-cell problem. Bacterial infections typically suggest an antibody or B-cell problem. There are very specific types of viruses, like the family of herpes viruses, where we have to start looking at the NK cells. These people have very severe, life-threatening herpes infections. And then there's some other types of infections, skin infections, soft tissue infections, where we might be looking at specific types of white cells, or specific infections like meningitis, recurring, that we would say, that's a complement system. We know that protects against things like meningitis. So again, getting the history, being organized, and understanding what are the infections or what are the problems that you have had or your family member have had, that tells us where we should be looking. Where should we be shining that flashlight and doing the testing? And so just to sort of go a little bit further with this, understand that we've divided the immune system just mostly for organization to sort of systematically go through it into these compartments. Now, this is, some would argue appropriately, this is a little bit outdated because as we've learned more about immunology, these systems all talk to each other. They're all intertwined, and so it's a little artificial to put things in boxes like this, but it helps us to walk through the different types of tests that one can do. So you can see you have the cellular immune system, that left column. These are the cells. And I think everybody sort of probably understands your immune system is made up of all different kinds of cells, some of which are listed there. And on the right is the humoral immune system. Does everybody know that word humoral is a strange word? It comes from Greek times when Greek physicians thought there were 4 humors of the body fluids that were important. And just because it's after lunch, I'll tell you those were blood, yellow bile, black bile, and phlegm. That's a pleasant thought, right? But at any rate, humoral kind of means the bloodstream, the body fluids. And so these are not cells. These are proteins or other components that float around in the blood and have important immune functions. And then you also see here we have the innate and the adaptive parts of the immune system. The innate immune system is the first line of defense. It's always there. It's sort of ready and looking for problems, and it responds very quickly. So we all need our innate immune system. It includes your skin. It includes neutrophils that if you cut yourself, immediately go to the site to try to contain the problem. So the innate immune system is very important. It's actually much more complicated than we ever thought. The innate immune system, though, is pretty inflexible. It kind of does the same thing over and over, no matter what the problem is, what the invader may be. The adaptive immune system is really, I guess you'd say, the more intelligent part of the immune system. It's flexible. It can learn. When you get a vaccine, it learns to recognize that bacteria. So in the future, it can mount the response much stronger. And the T cells are constantly learning what's around you, what it needs to fight against, what it can tolerate. So that's the brains behind the immune system. But it's slower to act. It takes a little longer for the brains to sort of figure out what it needs to be doing. So these are just, as we walk through, just recognize these are different buckets that we need to think about as we're doing laboratory testing. And then we have all of these cool cells, and I'm not going to go through all of these, but T cells and B cells and macrophages, and again, my friend the dendritic cell up there on the right looks like an octopus this time. All kinds of cells that we can look at and measure, but also understand that these cells have some plasticity to them. And so in the background of this cartoon on the right, you see things called cytokines. These are chemicals that the immune system makes and signal cells to change or to migrate or to do this or to do that. And so there's plasticities to these cells that they can mature into something else to do a specific job. So this is all to say there's a lot of complexity, a lot of components, but also a lot of dynamic changes that happen. And we have to account for all of this when we're going to do a test, right? We have to figure out what are we measuring and what's normal and what's not normal. So if you remember one thing from this talk, I hope you remember more than that, but this is a really important thing at the bottom. It's important when we talk about the immune system to evaluate both the quantity and the quality of the immune response. So that means we want to count things. We want to count cells. We want to count antibodies. We want to count the things to make sure that the levels are where they should be. But we also are very concerned about quality, meaning that we want the cells or the antibodies that are there need to be able to do their job. They need to be functional. And so I'll use this. Some people don't like sports analogies, but I was a soccer player. I love the sport. There's actually some big soccer tournaments on TV right now. And so I use this analogy with my patients. When we're looking at your immune system, we first got to make sure you got enough players. Okay, so if you're playing against a team, a squad of bacteria that have a full squad, and you're missing half of your team, you're in trouble usually. Okay, so the quantity, the numbers of cells of antibodies are very important. But we also need to know that your players, your cells, your immune system can do their job. And so if they're sort of lazy, not doing what they're supposed to do, or maybe they're depressed for some reason because you're on a medication. Maybe it's injured. Maybe your immune system is injured somehow because of a genetic issue or, again, because of some other medical treatment. Or maybe your immune system's distracted. It's taking selfies and doing things that aren't relevant to the game. But you can think of this as maybe your immune system's misbehaving. You have an autoimmune problem or an inflammatory problem. These things matter. And so increasingly, we're trying to look at ways to measure not only are all the pieces there, but are those pieces doing what they're supposed to do? And that's the quality or the functional component that's important not to miss, not to forget about. All right, so all that said, we get into this when we look at lab results, what's normal and what's abnormal? And you might say, well, that's easy. It says they're right on the paper, what's normal and what's abnormal. Yes, but I want you to understand, why does the paper say that? Okay, so when laboratories do tests, they run what are called normal controls, and these are identified healthy individuals where they do the same tests in those people that they're going to run on people who may be sick. All right, and this is usually adults. It's usually, they try to divide it between males and females so that we account for any differences. And there are some slight differences between men and women in terms of immune function and immune measurements. And so they use these normal, usually several hundred or thousands of people, to figure out what's normal. What's the range that you see in normal, healthy people? And I put normal in quotes because, normal is sort of a relative term, but you understand what I mean. These are healthy people. They don't have immune problems. They don't have major health issues that we're aware of. All right, and so the common statistics that lab uses is they consider a 95% confidence interval. So that means that 95% of these, quote, normal, healthy people fall within the range when you do a lab test. So here's an example. This is IgG levels from 1,000 people or so. And if you pulled 1,000 people off the street and you said, you're well, right? You don't have an immune deficiency, you don't have a problem, this is what you would get. You would get these numbers, their range. Humans are quite variable, so you get lots of different numbers. And I can tell you, I'll get to this in a moment, but anything below 700 is sort of what a lab says is below normal, and anything above 1,500 or 1,600 is what a lab says is normal, or is above that would be abnormal. And so what you get here is what we call a bell-shaped curve, or a normal distribution. And I'm not going to bore you with this too much, but it's important. I want you to understand that bell-shaped curve, you see that pink line in the middle, 95%. That's what the laboratory says is normal, okay? Now, what that means, though, is that on each side of that 95%, 2.5% at the bottom, 2.5% at the top, those people are totally healthy, but they're outside the normal range, okay? And this goes back to what I told you about. We always have to take that result back and go to the person and say, you have any problems related to this? Are you getting sick? Are you having issues? Because there are normal, healthy people that are above or below that normal range, and that's fine. If their health is fine, we don't worry about that because they're still normal. It's just that they're not in that 95% that the laboratory uses based on these statistics. So remember this bell-shaped curve normal distribution. This is true for almost all laboratory tests that we do, all right? And these are just stupid dad jokes. We just celebrated Father's Day. My dad likes stupid jokes. So here's the bell curve and the Liberty bell curve. That's not scientific at all. It's just funny. And here's the normal distribution and the paranormal distribution. So that doesn't really exist, but it's an interesting thought. Okay, so just to reiterate, 5% of normal, healthy people fall outside of this range that the lab says is normal, all right? And so, as I mentioned, just getting a lab result outside of that range does not mean that you have a clinical problem. That's based on your symptoms and how you're doing health-wise. So always interpret tests in the clinical setting. And the other thing I want to make sure that you're aware of, which you probably are, but whenever we do immune testing, we have to take a very close look at people's medications. We are increasingly seeing over the years more and more people with what we would call secondary immunodeficiency. That means that they're on a medicine or have been on a medicine, and sometimes these are chemotherapy drugs. It could be oral steroids. It could be a number of immunosuppressive drugs for lots of different conditions these days that will cause their labs to look abnormal, okay? So if you look at the global population, the leading cause of immunodeficiency is actually malnutrition. Now, we don't have that problem, at least not in epidemic proportions in the United States, but malnutrition or medications actually will cause major abnormalities on these lab tests in some people. So just make sure that if you're going through an immune evaluation, that you and your doctor talk about, am I on any medicines that might affect this? Now, you may not be able to stop those medicines. There may be good reasons to keep taking it, but you got to keep that in mind when you interpret the results. And then lastly on this point, age-specific levels. So the measurements, immune measurements in an infant will be very different from the immune measurements in a 20-year-old or even an 80-year-old for that matter. And so for kids, this has been worked out pretty well, but it's important to interpret any results according to age-matched controls. That means look at the pediatric normals, not the adult normals. We know a little less about what happens when you become older, 65, 75, 80, 90. There are immune changes, but those are not as well established. So whenever we can, we want to try to match the controls to the age of the person who's being tested. All right, so we're going to talk about some tests now, and usually we start with sort of the most straightforward tests, and we get more complex as we go along. And so this is a little bit of an iterative process, meaning that when you first see someone, at least in immunology, we're probably going to suggest a panel of tests, and then we're going to look at those, and we're going to, of course, follow your clinical course, and we're going to use those to decide where do we go next. And this is, of course, a dynamic and ever-changing field, particularly when we start to talk about the genetics, which I'll touch on in a moment. So this is a little bit artificial. This is not the Bible about immune testing, but just to give you an idea of the complexity. You start with very simple things. This, as I said, number one always is taking a careful history, understanding the story, the journey of the person, doing a physical exam, and then looking at simple things like blood counts, chest x-ray if there's pulmonary issues, and I think immunoglobulin levels should be done pretty early. Many of you, I'm sure, have been through this, but that's a pretty straightforward test to get, and if that's abnormal, we know that we need to dig deeper and figure out why is that, and what else do we need to look at. Then we get into functional titers. So this would include responses to vaccines. If you've not had vaccines, then considering getting those and testing your response to those. IgG subclasses is here. I will tell you it is controversial amongst immunologists as to how valuable subclasses are. That's because a lot of normal healthy people have subclass deficiency. It doesn't ever cause them any problems. And so it's a little hard to know whether that finding actually translates to any risk of infection or other issues. But it's there because there are immunologists that think that's very important, and it's the old saying, if you ask 10 immunologists about this, you get 12 different opinions. So we need to learn a little bit more about subclasses. And then we get into a little more complex testing. So counting cells, and specifically different types of lymphocytes, looking at the function of those lymphocytes. If there's concern about a condition like CGD, then we test neutrophils through something called DHR testing. And then number 4 there is getting pretty specialized. And we only send these tests, with the exception of genetics, so that's the reason it's red, but we only send this list in number 4 if there's a very specific history that suggests a very unusual immunodeficiency. So I think, we don't often go to box number 4 except for genetic studies. And the reason it's red is because historically it's been way down there. I think we're now at a point where that should be moving far up the list in terms of testing that we at least discuss with our patients. And so, talking about molecular testing, this is a panel, a gene panel for immunodeficiency. This is an old panel. I left it here. I gave this talk a few years ago, and I found this slide. You can see about 200 genes on this panel. Just in the last few years, this panel has changed to this. So as I mentioned, we keep learning new things that we need to be looking for. And so now we're up to, this is the smallest gene panel that this company offers, 429. There is another panel that's well over 500 genes now. So you get the point. It's just the universe keeps expanding and we need to keep growing with it. And that includes genetic testing along these lines. All right, last thing before we talk about some specific tests. In this universe of different immunodeficiencies, most people will have some evidence of antibody deficiency. And so that's why there's a lot of talk about immunoglobulins, about immunoglobulin treatment, because at least 50%, and if you fold in the 20% there with combined immunodeficiency, it's probably close to 70 or 75% of all people with primary immunodeficiency have an antibody problem sometimes along with other things. So these others, they're important, absolutely, and we need to think of them and test for them, but they're just not as common as the antibody deficiencies. So that just gives you a feel for, as we talk about things, how often do we find abnormalities in these different areas. Okay, so let's talk about a few tests. I talked about measuring levels, and you guys are very familiar with immunoglobulin levels, so IgG, IgA, IgM. Got to measure that. It's often one of the first things we do. And IgG is, of course, the most important of these. IgA and IgM in and of themselves, yeah, a few people will get into trouble if they're missing those only, but most people with IgA deficiency, and probably the majority of people with only IgM deficiency, are actually pretty healthy. So we really pay most attention to that IgG level as a marker of antibody deficiency. And then I mentioned function, and we measure function by looking at specific antibody titers or responses to vaccines that most people have had in their lifetime. May have been when you were young, but you've had, a tetanus shot, a diphtheria shot, a Haemophilus influenza shot, a pneumonia vaccine. If you haven't, then we can't be certain you've been exposed to that. And so we would often, if the levels are low, give that vaccine and then measure the response. And so that's reflected here. If the levels are protective, we know that you respond to the vaccine, you have good functional antibody titers, good functional responses. If they're not protective, if they're low, then we discuss with people, probably a good idea to get that vaccine, and then we'll go back a month, 4 to 6 weeks later, because that's how long it takes for that immune response to ramp up. Remember, I told you the adaptive immune system is very smart, but a little slow to act. So it takes a few weeks for those levels to come up where we can measure them. And then we measure the post-vaccine titers. And so you can see there are cutoffs for these things. There's some rules that have been published on how many titers should be protective for the pneumococcal vaccine. And we use that to sort of judge how good is your functional immune response. Now, the other thing we use IgG levels for, if you're on immunoglobulin treatment, of course, is to monitor. And so this is part of the lab testing we do once we've made a diagnosis. This slide was shown earlier today in an earlier talk, but I think it's really important because, again, those levels matter. We want to make sure if you're on treatment that you're at least in the normal range for IgG, but don't be fooled into believing that there's any magic number that one has to achieve for the IgG level. And this was just cases published by Vinny Bonagura, a colleague, that just showed that these folks, 2 different people needed 2 different levels to stay healthy. So that dotted line in each of these graphs he called it the biological level or the biological trough. For the first person, it was 900. If their level was above 900, they didn't get sick very often. The other person was good at 700. They stayed above 700, they didn't get sick very often. But it's different from person to person. And so, again, just a plea, don't get too caught up in the numbers. The numbers matter. That's why we look at them. But most importantly is, how are you doing on the treatment? We got to use that along with the numbers to adjust therapy and make sure that it's working as well as it should. And the other thing I want to say about measuring antibodies is that once you're on immunoglobulin treatment, it will interfere with a lot of other tests that our colleagues like to send. That's particularly true for infectious disease, where they measure antibodies to different bacteria or viruses, and it's particularly may be a problem for rheumatology, where they measure antibodies to your own tissues. Remember, when you get immunoglobulin treatment, you're now getting antibodies from literally thousands of other people. And so when you get your blood drawn on immunoglobulin treatment, they are measuring antibodies from the general population, not you anymore. So I have to remind my colleagues, if you send, anti-thyroid antibodies, or you send an antibody to the latest virus that's going around, and you're getting immunoglobulin treatment, probably not accurate for you because there's interference from that treatment. So at the bottom there is a couple of pearls. I think it's really important to try to establish the diagnosis before you go on immunoglobulin treatment, because once you're on it, it's very hard to go back and measure these things. You have to stop the treatment, basically, which you don't want to do if it's helping you. So making the diagnosis before you start the treatment, and then once you're on the treatment, your other specialists need to know they probably can't rely on their usual antibody tests as much as they would in someone not on immunoglobulin treatment. They really got to use other tools to make that assessment or make decisions. Okay. Back to counting things, we can count lymphocytes. Again, here's our friends, the B cells, the T cells, the NK cells, and we can use a technique called flow cytometry to measure these very specific populations of cells. So this looks complicated, and it is a little bit, but flow cytometry works, believe it or not, by taking a stream of these cells and hitting them with a laser. That laser can actually measure how big the cells are. It can measure how complicated the internal contents of the cells are. And it can actually measure, if you put markers for proteins on the surface, it can sort based on those markers that you put on the cells. So flow cytometers can measure 10,000 cells in a minute through this laser, and they sort them. They sort them into groups based on size and complexity, going on the horizontal here, that's called forward scatter. That's how big the cells are. And the vertical one is called side scatter. That's how complex the internal components of the cell are. And you can see here, they cluster into groups. There's the lymphocytes in the red. There's the neutrophils and granulocytes, the big there up on the right. And then you can take those lymphocytes and you can sort them into B cells, T cells, and K cells. And in fact, like I said, you can put colors on these cells or markers for their surface proteins. And then these are T cells that you can sort into CD4 cells, which are helper cells, or CD8 cells, which are cytotoxic T cells. So this is a way that we can look at all those cells I showed you. We can count all those cells and make sure that the right numbers are there, that you're making the appropriate types of cells to make your immune system work. We can also look at the function of those cells. So this is something called a lymphocyte proliferation assay. And this involves taking those lymphocytes, putting them in a test tube with some antigens. There's different antigens that we know the immune system will respond to, will rev up against, and then measuring how well do those lymphocytes activate. Do they ramp up like they should in the presence of a pathogen or antigen, or are they lazy and they just kind of hang out and don't do what they're supposed to? This is an older slide, used to do this by adding radioactivity, that you could actually measure the division of cells based on the amount of radioactivity. Turns out that that's a little dangerous to do, and we like safer ways to do that. So now it's done, again, through that flow cytometry. You can label these cells, and you can actually measure how frequently they divide and proliferate. So this is a pretty specialized test, and that's why I put it at the bottom. This does usually require an immunologist or at least a pathologist to read this, because they have to compare it again to a normal sample and determine whether your lymphocytes proliferate correctly. And then a word about cytokines. People have heard of cytokines before? Yeah? Cytokine, the word comes from Greek. It actually means cell movement, cell kinesis. And cytokines, which are represented by these streaks down here, the red, blue, and green streaks, these are basically signals. These are chemical signals that the immune system uses to communicate. So you can see this T cell is calling over the macrophages, say, hey, come over here, I need you to work on this problem we have. And there's lots of cytokines. Last I checked, there's more than 250 cytokines that have been described in the immune system. Now, you can measure these cytokines. There's so many of them that it's hard to know what that means most of the time. And you can see here, the T cells, he says, you look psychotic. And he says, don't you mean cytokinic? We don't know very well how to interpret cytokine measurements. There are some specific conditions. For instance, there's an immunodeficiency where people are very susceptible to mycobacterial infections like tuberculosis. That has been traced to a very specific cytokine pathway and deficiency. And so there are times where, based on the story, based on the history, we would go hunting and look at specific cytokine levels or cytokine receptor function. I say say this in part because I have seen now some patients bringing in cytokine profiles. They measured, 27 cytokines, and they say, look, what does this mean? And I say, I have no idea, because it's so variable, the cytokines, from person to person and over time. So I think we have a lot to learn about cytokines. They're very important in the immune system, but I don't know that we have our arms around how best to use that in most cases. Again, select cases, there may be reasons to look at very specific cytokines, but I think you have to know what you're looking for and why. And then I mentioned neutrophils before, so this is a test very important for CGD. Again, always start with counting things like the neutrophils, make sure there's sufficient numbers. But this is called a DHR test, and this basically measures the oxidative burst. So neutrophils get rid of bacteria by this burst. Basically, they make hydrogen peroxide, more or less, to kill the bacteria. And CGD is a condition where genetically people can't make that burst, and so they start to get abscesses and other infections. This is just a way to measure that burst, and you can see the normal is in the upper left. There are two different genetic types of CGD here in the lower left and the upper right. Though you can see that doesn't look the same as the normal response. And what's really interesting about this test is you can pick up people that are carriers. So there are women that carry this, but it doesn't affect them because they have one normal gene. And you can pick up a mom that may be a carrier there by she's got one set of cells that work perfectly fine and one set that don't work very well. Most of those individuals are healthy, but they have a risk of giving this to their sons. All right, and the last system I'll mention is the complement system. Fortunately, complement disorders are pretty rare, so I won't spend much time on this, but I just want to point out, if this looks complicated, it is. There's a whole slew of proteins that act in a cascade to form the complement complex, which basically, at the end of the day, punches holes in bacteria. It's a very ancient part of the immune system, but very effective and very important. And so if we suspect complement deficiency, and there are very specific infections that suggest that, we can start with this thing called a CH50 and an AH50, which will sort of give you a summary of these pathways. But you actually, if there's any abnormalities there, you have to start testing individual components. And you can see there's lots of different proteins that can either be low or not working properly. All right, the last thing I want to mention is genetic testing in the last 5 minutes or so. So, as you guys all know, we talked a lot about symptoms. They're the red person. We've talked about cells. We've talked about proteins and antibodies and cytokines. But as you well know, we're starting to think more about the root cause of these things appropriately. Why? Why is this happening? Why is the immune system malfunctioning? And so we're more and more looking at genetics. And so just a quick word on genetic testing. There are many ways to go about genetic testing, but these are the three most used these days currently. Gene panels, whole exome sequencing, which is the WES in the middle, and whole genome sequencing on the far right. And I just want you to try to understand what the difference is here. Gene panels are looking at a list like that 427 panel I showed you of genes that we know that those can cause a problem in the immune system. We know that they can cause immunodeficiency if there's a problem in those genes. So we're looking for what we know to be an issue, at least for some people. So that's a panel. Whole exome sequencing is actually sequencing the part of the DNA that encodes for proteins. And we think, although there's a lot of research going on this, we think a lot of diseases, not just immunodeficiencies, but a lot of diseases are caused by protein translation going wrong, meaning that your DNA codes for a protein that doesn't work right. Okay, so there's been a lot of work looking at whole exome sequencing. That's actually only about 10 to 20% of your DNA, is this part that we know makes proteins for your body that's essential for your function. And then whole genome sequencing is actually sequencing your entire DNA, everything that's there. And again, as I said, 80% of your DNA, we're not really sure why it's there, what it does. It probably has important functions. These are things called introns that don't code for proteins, but might tell proteins when to encode, might have start and stop signals. But that's whole genome sequencing. So from left to right, a little bit of data, a fair amount of data, and a whole lot of data on the far right. And part of the issue with whole exome sequencing and whole genome sequencing is interpretation of that data. We call that bioinformatics. And bioinformatics is incredibly complicated, meaning you often need whole teams of people to look at all that data. And the reason is that you have these nucleotides. This is what your DNA looks like. These nucleotides, the numbers there, T, C, G, and A. Anybody want to guess how many nucleotide pairs you have in your DNA, every one of us? You have at least 3 billion nucleotide pairs in your DNA. Okay, so when we talk about whole genome sequencing, you are sequencing 3 billion pairs. And someone has to look at that and say, I think there's a problem in this one right here. Okay, so that's bioinformatics, and that's the real challenge. Technically, it's actually pretty easy, and it's becoming less and less expensive to get this data. The problem is on the back end. Who's going to tell you what it means? And again, universities are often very good at this. They have whole teams of people. But your average doctor sitting in the office, he doesn't have that expertise. Nor does he have the time to do this for all of his patients. This takes weeks and weeks of looking at a single person's DNA. So anyway, the long and the short of it is we're looking for variants. That's the red circle in the far left. We're looking for a change that's not seen in most of the population. And we all carry, they've done studies, we all carry thousands of variants, each one of us, that are not quite what the rest of the population has. Most of those are probably benign. They don't change anything with our bodily function, but that's part of the question is which variants are important and which aren't. I show you this data this was Jordan Orange and Ivan Chin a couple years back. They looked at these different types, and it's a little bit busy, but they looked at gene panels on the top, and then exome sequencing, different types of exome sequencing in the bottom two. And what I want to point out to you, I don't know if I have a pointer, but I don't. But the upshot here is that the gene panel does actually quite well. It catches 24% versus 25% for exome sequencing in one study and 28% versus 26% in the other study. So the gene panels are actually pretty good for primary immunodeficiency. They're not perfect. And what on the left side of this graph, if your parents are related, we call that consanguinity. If your parents are related to each other genetically, then the whole exome sequencing is better because now you're running into very unusual things that won't show up on the gene panel. But for the general population, gene panels do okay. And so I think my view is I'd push my patients, consider that. Talk to your doctor about that because that's something that at least in the office-based setting that's doable for most. Now, last thing on gene panels. Whenever we do genetic testing, there's 3 possible outcomes. One is we find a mutation that we're looking for. Aha! That's why you have immune deficiency. It's been described. We know that's the problem. Number 2 is we don't find anything. The gene panel comes back clean, clear. Okay, well, we looked at what we know to look for. Doesn't seem like there's anything there. But probably the most common thing I see is variants of undetermined significance or uncertain significance, VUSs. And that's the shrugging doctor at the bottom right. Nobody likes to see the shrugging doctor, but that's the truth. A lot of times we don't know what to do with that information. So these VUSs, this is just a sample report. You can see uncertain significance. And so this is where we have to go back to the literature, to the patient, to the story. Does any of this make sense based on that gene and what we know that gene does? And this does take a little bit of time. I think this is some of the reticence to order gene panels that we see amongst clinicians. But this is very common. So if you have genetic testing done, just be prepared that this is a possible outcome. And I always try to temper people's expectations with genetic testing. It's not a black or white answer. It's often very gray in terms of the data that we get back currently. But why do we do it? We do it because in roughly a third of people with primary immunodeficiency, it actually makes a difference. You can see on the far right graph, it either changes the diagnosis or the treatment plan, or at the very least allows counseling to the family to say, this is or isn't a genetic problem, at least based on the testing we can do. And so 33, 35%, it actually makes a difference. And that's pretty good. I think that's reasons to think about it, because for a third of people, it will actually change what we're doing. So I'm going to wrap up there. I know that testing can be annoying. I know it takes a long time, It's a test to see if we need to do more tests. That is true because we have to sort of work our way through this very complex system. But I hope some of this will help clarify maybe a few questions. My advice to you is just keep moving forward, get as much information as you can, but understand, again, the most important thing is how you're doing clinically. The labs are just a tool to try to help us improve that. Thanks very much for your attention.